We are live, sir. You can start. Thank you.
Let's start. Good evening. Today my case is about Ansh, a 1 year, 3 months old male child. Yes. My case is about Ansh, a 1 year, 3 months old male child who is first by birth order and born out of second degree consanguineous marriage, Hindu by religion, Singh by community, residing in Chembur and hailing from Uttar Pradesh. Hindu by religion and Singh by. Is brought by mother who is the informant and reliability is good with complaints of loose stools for 5 to 6 days and complaints of fever for 3 days. The child was history of presenting illness. The child was apparently normal 6 days back, after which he has developed complaints of loose stools for 5 to 6 days, around 4 to 5 episodes per day, which is watery in consistency, large quantity, and yellow in color, not associated with passing blood or mucus or worms in the stool, and not associated with perianal excoriation or redness. After 2 days, the child had fever, which is of low grade, undocumented, not associated with the rash, chills, and rigor, around 2 to 3 spikes per day, intermittent in nature, which is relieving with completely with medications, and the child is active in interfebrile period. History of presenting illness, significant positive history of poor complementary feed introduction present, and child is predominantly on milk-based diet, and history of FICA is present. No history of cough and cold, no history of fast breathing or chest and drawing, no history of lethargy or refusal of feeds, no history of persistent inconsolable cry or convulsions, no history of reduced urine output and cry during micturition, no history of vomiting, or no history of poor no history of recurrent loose stools or respiratory tract infection, no history of poor weight gain according to mother, no history of ear discharge, no history of decreased oral intake, no history of any feeding difficulties, no history of previous hospitalization or recurrent nebulization, no history of bluish discoloration of body or failure to thrive, and no history of COX or COX contact. For these complaints, child has been consulted in pediatrics OPD. Symptomatic medications were advised, and the mother was told by doctor that child's growth is less according to his age. NRRC reference was done, advised to admit the child for nutritional rehabilitation. There is no significant past medical history present. Antenatal history. Spontaneous consumption at 21 years of age, first by birth order, no history of any fever with rash or excessive vomiting, bleeding or leaking per vagina in mother during the antenatal period. Mother is a known case of seizure disorder since 6 to 7 years of age and on daily medications for the same, and she is following up for a seizure disorder in her own hometown. No history of any change in medications during pregnancy. Antenatal scans were done 4 times. All were told to be normal, and but the mother has not taken any iron, folic acid, and calcium supplements during pregnancy, and the mother couldn't remember her weight gain during pregnancy. History of transmission in the third trimester present for in view of low hemoglobin. Birth history, child is a full-term baby. Emergency LS born by emergency LSCS, which is done in view of mother had convulsions at 9th month of gestation. Child was born and cried immediately after birth. His birth weight was 2.5 kg. Since mother was admitted in ICU for her illness, baby was fed with milk powder in appropriate dilution by Vati spoon feeding. Initially, 2 hourly feeds were given, and the child tolerated it well. No history of any neonatal jaundice or convulsions or lethargy or fever or weight loss present. The child was discharged on day of life 8 once mother recovered from her illness. Breastfeeding was not established during discharge from the hospital. Developmental history, gross motor. Child has achieved his neck holding at 6 months of age. Rolling over was attained at 9 months. The child sat with support at 12 months, stood with support at 13 months. The child is currently 15 months of age and he can't stand without support or walk with support, according to mother. Fine motor, he can lift small objects with 2 fingers. Little mature pincer grasp is present. He can drink from cup and eat with spoon with spillage. Socio-adaptive milestones. He responds to name when called, waves bye-bye, plays peekaboo while covering face and can't indicate wet pants. Language, according to mother, the child is having bisyllable speech. His gross motor is around 60 percentage and language is 50 percentage. Total developmental quotient is around 77 percentage. He is having language delay more than gross motor delay. Dietary history. Breastfeeding was started by mother on day of life 9 along with the top milk initially. Once a child has started accepting the breast milk will, the top milk has been stopped and the child was started an exclusive breastfeeding till 6 months of age. And child feeds once in every 1 to 2 hours. On-demand feeding was given. Each feeding session lasted for around 30 minutes. Night feeds have been ensured by mother and no history of any feeding or latching difficulty present. At 6 months of age, child was started on complementary feeds with mashed dal and rice in thick consistency, and the child is having a history of poor acceptance to complementary feed present. According to the diet chart, child is predominantly on milk and dal khichdi, with only 3 to 4 food groups are given to the child. No vegetables or fruits are been included. Intermittent breastfeeding around 4 to 5 times. Intermittently, child was breastfed around 4 to 5 times per day. His expected calorie intake according to his age expected weight is 960 kilocalories. There is a calorie deficit of around 360 kilocalories and expected protein intake is 14.4. There is no protein deficit. Protein deficit is not there. Then immunization history. The child is immunized till date according to national immunization schedule. No optional vaccines have been taken. Socioeconomic history. He belongs to lower socioeconomic status according to modified Kuppuswamy scale. He lives in semi-pakka house which has separate kitchen and no separate washroom present. The house is not adequately lit and ventilated. Uses corporation water for drinking and not boiling the water before drinking. Average duration of sunlight exposure in a week is around 2 to 3 hours. Clinical summary.
So what do you make out of the first complaint? 1 year, 3 month old. No? 1 year, 3 month old, loose stools for last 5, 6 days, watery, all that description is there. So what do you make out?
Acute gastrointestinal infection.
With the gastro part.
Loose.
What is a, when you say acute gastroenteritis, what do you mean? So initially starts with vomiting followed by loose motions. So there's no gastro part. Anything else? Come on, anything else? So why have you given? What do you think? Why have you given everything? What does everything mean or not mean when you have given it? So not associated with passing blood, mucus, worms tells you what?
It is not dysentery.
Tells you the anatomy. So where is the anatomy?
It is in the small intestine. Stool is of large quantity.
It is small intestine, stool is of large quantity. Not associated with perional excoriation. What does that? If there is perianal excoriation, what does that mean?
There is maybe malabsorption associated. secondary lactose intolerance may be there.
Okay. So perianal excoriation would mean that the stool is acidic. That's why it's causing that excoriation mostly. Though a small component is added if there are 20, 30 stools and the mother keeps cleaning and wiping. So that also adds to the redness. That redness is due to acidic stool. Acidic stool is due to lactose intolerance, which is mostly secondary, right? So which you see in most viral gastros, but it is not there here now. So does that mean anything to you if it is not? Does it mean it's not gastro?
No,
No vomiting, does it mean it's not gastro?
no.
Now, after 2 days, child had fever, low grade undocumented. So what does that mean? What does that low grade fever mean? Anything, whatever comes to your mind.
Because of dehydration also.
Why did you say dehydration?
Any infection, first it will be fever, then it localizes.
Okay,
But
so
no.
you may say that this low grade fever is not due to this illness or infection at least. Then when will dehydration cause fever? So what I mean is, suppose you get a classic rotaviral gastroenteritis with severe dehydration and shock. Do they get fever?
No.
So dehydration causing fever has to be in a selective subset or in a selective situation, not just dehydration causing fever, right?
Is this child a candidate for dehydration? Probably not. When will we expect dehydration? Too many loose motions usually associated with vomiting. Because on the one hand, you are losing, and from the other side, you cannot give the chances of dehydration. So anybody who has loose motions coupled with vomiting is a child at risk of dehydration. What does all this tell you? If you are not told anything more about this child and just told this much, what does it mean to you? You don't know so far the history, the birth history, etc. Just now it don't mean much because we don't know anything aage piche. So this child had a gastro, which is not an uncommon occurrence of fever a few days later is uncommon, and usually if it's an infection, it will start with fever. Fever will subside, often with vomiting. Vomiting subsides and loose motions continue. The sequence is little different, but maybe not. We can't bank on it, and we can therefore conclude something that is likely to happen. This by itself may not mean something very unusual about the child, unless you know the nutritional history, the feed history, etc. Just an episode of gastro for the time being. It is acute or malabsorption, or we'll have to wait and see.
As we always say, did you ask whether this child was absolutely all right before this episode?
According to mother, the child is absolutely all right before this episode.
The first thing is that the story starts acutely, but it has not progressed as a severe disease. A typical viral diarrhea of any kind, rotavirus or whatever, would start with explosive number of stools, which has not happened. So the onset may be apparently sudden, acute, but the progression doesn't suggest that it's simply an acute viral infection. That's number one. Second is the fever low grade does not mean anything at all for us to make out of it. A low grade fever could be a low grade infection. A low grade fever could be a low grade some tissue destruction of whatever cause. A low grade could be a partially immunized child, therefore he is not throwing up high fever. A low grade could be a host is not very strong and therefore he doesn't put up a good cytokine production. So low grade doesn't tell us anything about distance. That's number one. But it tells us that it is not an acute infection. Okay, whether fever came later or started off, the severity tells me that the problem must be chronic. And that's the first conclusion on this time. Okay. The number of stools are not too many. The child is not getting dehydrated apparently by the history. Then why did this child get hospitalized at all? That means the host must be abnormal. Now, what kind of abnormality? We will have to look into the details of the history. But certainly, this is not an acute onset severe viral diarrhea. Now, what else could it be? There is no vomiting at all. We said that the stomach doesn't seem to be coming much in the picture at all. So, whenever you have loose stools of some small number, don't forget it could be simply indigestion. Well, there could be indigestion leads to not absorbing nutrients. So we don't call it malabsorption because malabsorption would mean some part of the raw material is not getting absorbed. But every indigestion leads to loose stool. And why loose stool? Because they're not getting absorbed. But why not absorbed? Because they're not broken down at all. How can they get absorbed? They're just flushed out. So this looks like one of those. Infection cannot be ruled out at this point of time, but the first probability is it's an indigestion. And who gets indigestion? Somebody who gets acute illness, but this is not acute. Therefore, this child has to be failing to thrive. And right from this kind of a origin of the disease, we are expecting failure to thrive in this. Now, being a young infant, 1 year plus, could it be primary or could it be secondary? Now, to which we would have asked one more question that how was he fed to begin with? If he was breastfed, how has he been active? How are his milestones? Are they reasonably all right? And has he had any previous? Now, you gave a long history of newborn. I'm not. I was trained 60 years ago when no history was small. The rest of it was big. Today, no history runs into 20 points, which again and again we have made a point. No history of cyanosis for breathlessness. Which mother would bring you a child for diarrhea and not even tell you about cyanosis for breathlessness? Are the parents so dull? Then why are we giving a long list of no history? Okay, to me, that's not rational at all. I don't know whether that's the present way of teaching. Okay, and I jokingly say, only thing you have not said is no history of any neighbor having any disease. That completes the whole no history. But why are we giving such a big no history? Okay, and therefore, all that I know is this host is not abnormal. Being very small in age, 1 year plus, the first thing is, would it be simply primary? But at which you have said he was apparently all right. Now, don't say that mother said all right. What did you ask the mother? Why do you think it's all right? Did you ask that? No. So how will you be sure whether mother is right or not? Any thoughts on that?
According to mother, prior to this illness, child was active, playful, and eating food well. Uh,
Gaining weight, one thing, sir. And
If 1 year and plus old child, we are thinking he is likely to be abnormal, he cannot be playful and active. What does she mean by playful and active? So if 1 year and 2, 3 months, does he stand, does he kind of like to play with something? Unlikely. Unless you ask these questions, the mother would say, is all right. That is not all right. And we don't want you to repeat what mother feels. We want you to inquire correctly. Okay. And I think that is important because when when the police agency keep on asking the criminal, they can't say to their bosses, criminal says he is not involved. Is that the history? No. You need to find out from her what you want to know. And I think my impression here is this host is not normal. Why he's not normal, we won't know by this.
Okay, so no history, so it was very long, and sir has already said that try to make it more relevant. Now, let's discuss these some lateral aspects. So, mother is a known case of seizure disorder and is on daily medication for the same. So, how would that impact the baby? Would you have some thoughts on that? Would you look for something? Would you ask for something?
If she
Yeah,
was
she is on medication. No? She's a seizure disorder and on medication. So is that medication important for the baby, not important for the baby?
it is important.
So what will you ask?
If she knows the name of the drug, we can ask.
Okay,
And they are associated with congenital anomalies in baby,
very good. Like,
phenytoin, which causes fetal hydantoin syndrome. And if she's on, mm, it can also cause spinal defects,
so
like
neural
neural
tube
tube
defects. So as a corollary, what question will you ask?
Any in ANC scans, if any abnormality was detected,
Before that,
if she's on
Or not able to
she's
period.
taking that seizure medication or not, how regularly, one, and to prevent neural tube defects, what do you do?
Folic acid.
So you have to ask that history, no, whether she's taking folic acid, she was taking folic acid regularly or no. Not taken iron, folic acid, and calcium supplements. There is a history there. What impact? One is you will look for neural tube defects. What else?
maternal malnutrition can also cause fetal malnutrition. Anemia in the child is also contribute.
Yeah. So since she is not taking iron and folic acid supplement, what will happen? This baby will be born with a low hemoglobin.
Stores will be less.
Stores will be less. So what will happen eventually? So this baby will be born with a normal hemoglobin.
Yes.
So then what will happen? Which is different from the normal term baby.
Anemia of infancy.
Anemia of infancy, what will happen to that?
It will be earlier for
Very
the child.
good. One, it will be earlier. Two,
And the nadir will be more.
excellent. So the depth or the nadir of that anemia will be more. Very good. History of transfusion in third trimester.
In view of low hemoglobin in the mother.
So would you have transfused or would you have given iron supplements?
Third trimester we cannot wait, sir. So for
So how
build
big
up,
is third trimester?
it is 3 months. But at the end of that time,
So you have to ask, no, when in the third trimester? So if it is 6.5 months, beginning of third trimester, do you need to transfuse?
no, we can give parenteral or oral iron.
What is the advantage of parental over oral? How faster will the hemoglobin rise?
Same effect, but the tolerability, if they are not
So
tolerating,
ensuring delivery. And with oral, how fast will it rise?
Oral hemoglobin, if it's 1 point, then with parental line, it will be double the time with the oral hemoglobin down. The hemoglobin rise will be double the quantity with the parental line.
Hemoglobin rise will be same by oral or parental line.
Parenteral delivers it, ensures that it has reached. But what will be the speed of rise of hemoglobin if you were to give oral? We said 6.5 months is the third trimester. If you start giving oral, you've got about 8 or 9 weeks or 10 weeks. So how much will the hemoglobin, how much can the hemoglobin rise in those 10 weeks?
price is 1 gram per month.
1 gram per month, a week. Yeah, 1 gram per week. So it will be, so you have enough time. So again, you have to think when in the third trimester you have got that blood transfusion. Mother had convulsions at 9 months of gestation. So why she was not compliant with her medication
When on medications, the mother had convulsions.
even earlier?
While on medication, she had convulsions. Previously, she was very controlled.
Or anything like that which could explain hypertension. No. No, pregnancy induced.
Now, someone talk about the developmental history, or you talk about it. Tell us what is the interpretation of all.
Developmental history, there is gross motor delay is there. The child started his neck holding at 6 months of complete neck holding was attained at 6 months of age. Then rolling over, there is 3 month age gap between each milestones. Rolling over was attained at 9 months and sits with support at 12 months, stands with support at 13 months. But he still now at 15th month of age can't stand without support and can't walk with support. That is fine.
So you are saying that gross motor is delayed. Any other observation from this history that you got? So whenever you are looking at milestones, what else do you have to look at? In that milestone history, you have to take one decision in your mind.
The time frame is all the milestones are attained. Like what is the gap between each milestone?
In other words, you are looking at the speed
Speed.
or the rate, static or progressive. So what do you think this is? Static, progressive, worsening, or improving?
That is in the last milestone there is progress improving. Sir.
So there's improving, it's getting better. Okay. Now, why do you think these milestones are delayed overall in this child? Come on, just a general.
Nutritional cause will be the
Very good. It could be just nutritional. You look at all the other things, but it could be just nutritional. So now, if it is nutritional and it is getting better now, that means is the nutritional condition of the child also getting better? Has it got better? So then how have the milestones got better? So what I am trying to say is that this should make you suspect whether your history is right. So there could have been some errors in the history. So I'm just trying to say that when you get a sudden improvement in the milestone, see whether it is likely that it is the clinical condition is such that it will improve. Otherwise, your initial history could be reached.
If the birth weight was fine, and if there was a breastfeeding, then there was no reason why holding head and neck came at 6 months away, even if the nutrition was not adequate. Okay. And I think the only reason if head and neck controllers come at 6 months, to me, the head is large. And one reason why the head can be large is this child has a congenital hydrocephalus. If that was so, then he would not hold head and neck at the appropriate time and would be delayed. But then a rollover may not be delayed. Therefore, obviously, as you said, that the history is not probably reliable. You are repeating what mother has said naturally, but possibly she has not exactly given you the right thing. So possibly not. And more so because if 3-month-old child is not holding head to an extent that we want, then we know that there has been very close to a perinatal events or even antenatal, if there is nothing postnatal happening. That is not likely in this child. But what about the other domains? That is more important. And I think the other domains, 1 minute before you put it, are other domains likely to be abnormal in this child? And if so, how abnormal? Here, the improvement has started at 9 months or something. Okay, towards 1 year, the child is improving. So do you think he must have started recognizing mother also at 6 months? And now, of course, he's talking as well. What do you think? Make a guesswork.
You said mostly the cause is nutritional, delay motor milestone. So in a nutritional cause, do you expect fine motor, language, all that to be affected or not affected? What do you think?
No, we are not expecting such
Very
cause.
good. So nutritional cause should give rise to some gross motor delay, and by and large, that's about it, right? The other thing is, in these milestones, which are the more sensitive milestones, the earlier ones or the later ones? So by sensitive, I mean less time for variation, and the moment it is delayed, you are more worried. So what I'm trying to say is a 3-month-old head holding is delayed by 1 month or 1.5 months. And a 1 year walking is delayed by 1.5 months, which makes you more worried.
Later. The later ones, which are
Earlier ones are more sensitive and more very little range. So if social smile is at 6 weeks, if 8th week there is no social smile, I'm worried. I have only that much leeway. But walking 1 year, he may not walk till 15 months. But if everything else is okay, I'll say, okay, chalo, let me wait. Means I'll look at many other things. So the later milestones have a larger leeway and a lot of variation. The earlier ones are very sensitive. So
He made a right point. But why is it happening? He said 6 weeks. If you have not had recognizing, then by 8 weeks you are worried. Okay. He's giving you only an interval of 2 weeks to wait. But for standing walking, he said you might wait for 2-3 months. Where is the hurry? He may be fat.
Brain growth is rapid initially, then later the velocity.
Point
comparatively-
is the variation is same. If the variation is 25%, then at 3 months of age, that variation is only small, 6 weeks to 8 weeks. Okay. So that is why when a gross motor like standing, walking comes in, you have a, but the percentage wise, you are talking about the same. So if 2 weeks are given for a 6-weeker, 8-weeker to interpret. 6 weeks and 8 weeks. Okay, the difference is 2 weeks. So similar percentage of difference is same at 1 year of age. And there you have many reasons as well. Whereas at earlier milestone, the reasons are only perinatal or antenatal events and not acquired illness. That is the only reason.
Later on, the later milestones are dependent upon many factors, including the nutrition of the child. Well, for 6 weeks, even if the nutrition is this side, that side, it's really your cerebral cortex. And even if you are in hurry, you should never let the case go without asking in detail the social parts, whether mature, premature. You may have to give allowance because the variations are minimum at that age, while the variations go on increasing as the child grows. Well, multiple factors come. And therefore, did he smile? You must interpret, did he smile? The smile may have spontaneous smile. And the mother may feel that usually the mother will not do that. They are very sensitive. When did he smile? Did he look at you? Does he recognize you? Does he recognize your touch? They can smell a mother. Okay, child would not quieten with somebody else holding, but when the mother holds the child is quiet. These are quite sensitive to tell you right at that age, at least the higher centers may not be that much affected. Later on, we'll have to see.
Okay, now you said fine motor is normal and socio-adaptive is normal. And in language, you said there is a delay. So why do you say language there's a delay?
Child is currently 15 months of age, but he's still having bisyllable speech only.
So bisyllable speech is which component of language? Language has which two parts? Expressive and receptive. So bisyllable is
This is
expressive.
Expressive has again two parts. Yeah, verbal, non-verbal.
So you need to check the three other parts. So you've got expressive verbal as bisyllables, which seems to suggest that he is delayed. But you need to check expressive non-verbal and you need to check receptive verbal and non-verbal to see whether he is really as delayed as you think he is. You put it down as 50%. So what can you check in receptive and in expressive non-verbal? So first tell me what is expressive non-verbal and then we'll see what we can check.
He is able to understand what we are telling. If we tell no, then he understand it is a no. He stops doing that activity by 9 months.
So that is
It is expressive. It is non-express, receptive, non-verbal, receptive language.
receptive verbal. You are saying no, na? So receptive verbal. And if you do this and he stops doing, then this is receptive non-verbal because you are just doing a gesture, right? So now expressive non-verbal is also, you can go better than bisyllable 7-8 months. So what can you check in expressive non-verbal? That means you ask him something and he answers with gestures. And that puts his age beyond 7-8 months. He doesn't speak. Point. So now point what all? So here some cognition comes in. See, every milestone is not a pure compartmentalized thing. It has 2 or 3 limbs to it. So some cognition will come in. So what you need to understand is that a 15-month-old can understand what things and therefore assemble that and point. That is the way he's answering. So what all can you ask him?
Pointing to body part.
Very good. So pointing to body parts. So he should be able to point to 5-7 body parts, eyes, nose, mouth, etc. Then similarly pointing to common objects. So fan, light, AC, TV, whatever, family members, right? Then following instructions would be receptive language. So you give him 1-step instruction or 2-step instructions. So go to the room, go to the other room and get my mobile. So this is a 2-step instruction. And if he gets, then he has understood the receptive language completely. So then his language function is 100%, not just 50%.
His expression in the form of finger point. He wants something. So he may either say that, he may not express it, or he may just look at that. He may not even say that, but he will look at where is the toy? He will look at that. He may not say it. He wants something which is kept in that particular dabba, he will look at that and he may just say, huh? This is his speech, expressive but not verbal. So for everything, you know that he wants to communicate, though communication is not verbal. And it need not be. Non-verbal communication is good enough information for us, because ultimately he will talk. Okay, it also tells you that non-verbal communication is good. Things like autism, etc., are not like, because they will be affected. Both the communications will be, because it's a disorder of communication. So more than the expressive, if other things are okay and non-verbal is good and only verbal is affected, you are less worried. You may even reassure the parents, well, you wait, and in time to come, he will talk.
Now we have the breastfeeding history. So either from this history you judge and tell us whether breastfeeding was adequate or inadequate, or you tell us otherwise how to judge adequacy of breastfeeds. Because you said that first 6 months it was exclusive breastfeeding, right? So tell us.
Adequate breastfeeding.
You've given us a history that he feeds once in every 1 to 2 hours on demand, and each feed lasts for 30 minutes, right?
Yes.
So is this adequate or inadequate?
30 minutes indicating that both the foremilk and hindmilk the child is taking.
Mm.
And according to mother, there is no feeding and latching difficulties are there, and post-feed child should sleep adequately and his urine output should be good.
Yeah, so you asked all that. And in this child it was okay.
Yes. Yes.
So you feel this feeding is adequate.
Till 6 months. Yes.
Yeah. Now again, means it may be a bit of semantics, but you said every 1 to 2 hours. So if it is every 1 hour, then I would have asked, so does it mean 24 feeds in a day? This is a way to cross check whether it is really every 1 hour, because they may have some perception, right? And now every 1 hour for half an hour. So that means out of 24 hours, 12 hours are you feeding? You're getting my point? So it won't be that way, I'm sure, but this is the way you have to double check. And yeah. So besides what are the other indicators of inadequacy?
Child will be irritable due to hunger.
So the child will be irritable. What else?
History of poor weight gain will be there.
Okay, which they may not know, but yeah. Then Pallavi madam, can you mute everybody?
Yes, sir, doing the same. Yes, sir.
Any other point which indicates that is getting inadequate feed? Yeah, so sleeps adequately or no, then they don't want to leave the breast, or if they leave the breast, then within no time they want to feed again. So prolonged feeding and wanting to feed again is also a sign of inadequacy. Of course, they'll be irritable at that time. What about urine? You said adequate urine. So what is adequate urine? 6 to 8 times for life, from day 1 to 100th year of life. So urine is a marker only in the initial period. Okay? After that, urine ceases to be a marker. Why? So if you are malnourished or undernourished, what will be broken down in the body instead of carbohydrate, which is not there, and lipids. And the breakdown of that generates water, and therefore you would be passing urine. So urine is a poor marker beyond the first few.
And I think the other problem with the first few months is ability of the kidney to concentrate urine is poor. So many newborns or in the first few weeks, they may pass enough urine, but still it is inadequate. Because the kidneys cannot concentrate. The urine is dilute. To me, the best way is the color of the urine. And this is common to all age groups. If you pass colorless urine, then possibly you are passing enough urine. Otherwise, moment the urine starts getting concentrated, it starts getting a bit of color. And I think to me that is easy for parents to understand that what is it. Then of course frequency, quantity, but to me the color is the very good marker at all age groups, irrespective of frequency or volume. And I think that's why we will have to check whether it's adequate or not. But you already said that frequently asking, not leaving the breast for a long time at all, and then of course not happy about it.
Okay. Come, now give us the summary.
Clinical summary. A 1 year, 3 months old male child brought with complaints of fever and loose stools is a case of acute gastroenteritis with no dehydration. In a case of severe acute malnutrition with significant dietary calorie deficit and no protein deficit, with developmental delay in motor more than language in a fully immunized child admitted currently for nutritional rehabilitation. Anthropometry, child's weight is 6.96 kgs, which is less than -3 standard deviation, and length is 74 centimeter between -2 to -3 standard deviation. Head circumference 45 centimeters between -1 to 0 standard deviation. Mid upper arm circumference 13 centimeter between -2 to -1 standard deviation, and weight for height is less than -3 standard deviation. Impression is severe acute malnutrition with stunting.
This is cerebral palsy, motor involvement right from the early age. Okay, and a spastic CPs may be absolutely normal on other domains. And to that extent, because other domains, then we have a little problem with language as well, as put down 50%. So there are two domains involved. I think spastic CP. Can you roll out spastic CP?
No history of tone abnormalities given by mother, like any history of difficulty in wearing diapers. or handling the baby.
Child.
I wanted you to answer this question based on what you see on the slide.
Child's head circumference is normal. It is not microcephaly.
Head circumference is normal.
No question of CP here, but I just wanted you to pick up that head circumference is normal in spite of the rest of the parameters are not so good. What does it mean? Your weight, length, everything seems to be not as good as head circumference. Why is that? After all, nutrition is required for brain as well.
Great.
There has been some sort of brain sparing effect. The nutrition has preferentially gone to the growth of the brain and at the expense of the rest of the body.
So the nature preserves the brain first. You are absolutely right. What is the next priority for nature to preserve? Our heart. Head circumference will not be affected. Which other parameters would be prioritized after the brain is preserved? And the next obviously is length or height. Because the head has to grow in the first 1 or 2 years only. Okay. The height can grow right up to adolescence, but the weight can come even later. And you don't want too much of weight that you throw about weight on others. So priority wise, brain gets the first priority. Rest of the organs, of course, but the brain gets the priority.
Your mid upper arm circumference was -2 to -1 SD. So that's abnormal or normal? Normal. So then no malnutrition. No?
His weight per height is less than -3 standard deviation. So
Since I have a conflict between the two, which one should I follow? Since I understood that weight for height is less than -3, but mid upper arm is normal. What happened? It has got logged out. Have to join again. Chalo, meanwhile, you all answer. By mid upper arm circumference criteria, child is not malnourished. So what do you do?
The definition of SAM requires any one of the three criteria to be fulfilled.
Okay, very good. What else? So again, I'm just trying to say that when two things don't correlate, one step is go back and check whether you made a mistake in measuring. That is one. Agreed that you need to meet one criteria, and MUSC was originally used as a screening. So it was less for, it was lay people tool rather than a doctor's tool. But at least check whether your reading is right or not. Okay? Fine.
On examination, child is afebrile, active and interacting well with mother and surroundings, heart rate around 120 per minute, respiratory rate 26 per minute, saturation 100, notice vitally child is stable, pallor present, head to toe examination, head anterior fontanelle is open around 1 cross 1 centimeter, not sunken, sparse hair present, eyes and ears are normal, trunk and spine normal, Mongolian spots are present in the back, abdomen is normal, upper limbs and lower limbs are normal.
So sir is asking, is anterior fontanelle 1 by 1 centimeter normal at 15 months of age? He's saying it's big. So what do you interpret?
बच्चों को लेके आ जाओ.
Delayed closure of fontanelle tube may be the signs of rickets. Can be.
It is a sign of rickets. It's also a sign of hydrocephalus. So what do you think it's there here? Hydrocephalus or rickets?
Rickets. More probably rickets, and at circumference is normal.
So do you have any other causes for delayed closure of fontanelle?
Hypothyroidism.
So do you think this could be hypothyroidism? There are delayed milestones.
But the fine motor and social uh, domains are normal.
Bones are not growing well, no? That's why the length is small, weight is small. So the head circumference is also not growing, no? So there should be fontanelle very small. Bones are not growing, no? In malnutrition, anterior fontanelle must be very small.
Head circumference is depends on brain's growth than bone growth of bone. So brain growth is paired, so head circumference is intact.
What I mean is that when the bones are not growing, even the skull bones are not growing, therefore the fontanelle is big. Everything is slow, and that's why hypothyroid have even a posterior fontanelle is happening, because the bones are not growing. Okay. So that is all. Sometimes you may have to mention whether the inner table is closed, but the outer table is still open, which happens commonly.
They'll probably know that, not know that.
So here, in fact, you should not bring in hydrocef hypothyroid. You should say malnutrition is the cause of a large AF rather than anything else. And you should be able to argue against the other causes. So hydrocef you said is size of the head. Then hypothyroid is language and socio-adaptive normal. So not hypothyroid, not just motor, right? Yeah. So, we'll first see this way and then later maybe turn. Speak. Whatever you can find or observe, you can just speak.
The child is well, lying down and
Yeah, lying down comfortably in mother's lap. There is no obvious breathlessness, fast breathing, distress, looks to have little pallor. What about the hair? The hair circumference does not look very abnormal. The hair are sparse, but not discolored. Okay. So like that, you go on saying, do you think this particular child is too bad, lengthwise and nutrition wise, when you look at it now? Not too bad, even lengthwise. If you consider the length should be about 75 for a good length, he may not be too bad, maybe close to 70 or something. And for that length, the nutrition also not as bad as one thought from the caloric intake. Okay.
74.
That was very good, 74. Not bad at all. And for that length also, I think, look at the layer of the fat, look at the muscle mass.
No, sir.
No, sir.
Obviously, still it's not.
Point which sir always makes it, suppose we didn't tell you the age of this child, we just put this child and we ask you to take a call, is this child looking undernourished or no? What will be your call?
No.
And we said Sam. Okay. So take a note of that. Subcutaneous fat, muscle mass. Two things are important just to make an impression whether you are looking at a significant undernutrition or not. And therefore, this child has a reasonable both subcutaneous fat and a muscle mass, whatever we can see. Very little part of the body is seen, but even then, you can look at that. But is there an epiphyseal enlargement there at the wrist? What do you think?
Yes.
Yes?
Just widening it.
Would you palpate without disturbing the child? Really enlarged?
Because apparent enlargement is very common. Everybody has.
So if you see now here, if you start, this is an arrow, and here it gets a little prominent. That might suggest that there must have been, not necessarily an active rickets. So whenever you see some such thing, the next thing I want you to answer is whether this is an active rickets or a healed rickets or healing rickets clinically. Any thoughts? What are the signs of active rickets?
Pain during handling will be there. The child will be irritable while handling.
Okay, irritability. Muscle tone.
Tone will be less.
Let's discuss this pain and irritability. So, why do you think there is pain and irritability in our rickets? If there is pain and irritability, why is it there? Come on. Hypocalcemia?
Deposition will be there. With uncalcified cartilage, overgrowth will be there.
Was trying to say is that actually rickets is a compensatory phenomenon to maintain calcium in the blood. There is no hypocalcemia. So to that extent, pain and irritability is not a prominent feature, right? That's what.
I think you want to look at craniotabes. That's one. Second is you want to know whether there have been increasing deformity, which obviously means that the rickets is active. You want to know whether there are any subclinical signs of tetany. They're not easy to make out. I'm sure I can't make out easily the subclinical signs of tetany. And what are those signs?
Prospect sign and Rajiv sign.
It's not rare to see a little older child who has had rickets earlier in the first 6, 8 months of life, but still is maintaining a little prominent epiphyseal enlargement. And the examiner will ask you whether it is an active or inactive rickets. And such things are important. Okay. If this child is growing reasonably well, he has a reason to have rickets because his diet will be obviously not very strong in terms of vitamin D because he's not going out also. So sun rays is not available for him. And therefore, his length and the weight and the growth suggests that he must have had reasonable breastfeeding in the first few months. And it is at that time that he grew better. Thereafter, he is failing to grow. And even then, he's maintaining reasonably at about 12, 13 months of age, even if he's at 15. And therefore, many times they have signs of ricket which are healed rickets. So, my next question is how long does it take for epiphyseal enlargement, bleeding, such signs to disappear after you treat it? Any idea on that?
2 to 8 weeks.
Structural changes have to change. Structural, whatever abnormal, will it happen in 6 to 8 weeks? No, the changes may take a long time.
Considered bleeding is a sign of active ricket, better than anything else. And why is that? Epiphyseal enlargement is not necessarily a sign of, but if there is a bleeding, then that's very likely a sign of active rickets. And the reason is that area is constantly at stress because of our breathing. But the rest of the areas are not constantly at stress. And therefore that a reasonable good sign. So maybe when we examine him, if it's possible, when he's not going to cry, you should say whether there is bleeding over it.
Neotabis is, but at this age it is difficult, the smaller the baby. Sir, I was thinking hypotonia and little delay in the development, cross motor development is important. We see the craniotabis. Because I saw near the anterior fontanelle and everybody had craniotabis.
Parietal eminence.
Away from this, the back, occipital, parietal, and you see whether there is or there is.
Fully. But what are the priorities of examination? Color is seen. So you know there is some iron.
And there has been history of seizures, this, that, and all earlier. So the first look we should see whether the child is dysmorphic or. Okay, and this doesn't require more than a minute and just no touching the child. Do you think this child is dysmorphic? No.
No.
You tell me whether this hair changes are protein changes, amino acid changes. You said sparse hair. Yes. Is it normal?
Can be due to
Can be genetic also.
So tell me by examination of hair whether this sparse hair is protein deficiency or not. If you say it is not, then we'll see what it is.
Protein deficiency will have easily pluckable hair and alternate bands of the hypo and hypo.
Because he said they are not discolored.
And sparse means how will you see this artery? Okay, easy pluckability. Without trying, if you pluck very hard, everybody will have. Just easy pluckability, it comes back. And then the pattern of patchy, because anywhere you can just figure that out. Right. And the alternating bands of light and all will come only in a child who has borderline malnutrition. Is improving, the color changes. Then it deteriorates, then the color goes down. Otherwise, not very common. And not very commonly seen either.
So this is not protein deficiency. Then what is it? Normal infants start losing hair as well. Okay, thereafter, then that losing hair. To begin with, there is the lanugo hair, which is lost. Even the scalp hair is often lost in the first few months, not to a point of baldness, but certainly, and then they start growing again. So this is of no significance at all. You mention it's harsh, but you also say that that's not significant, right? Abdominal distension, you want to see. But do you think a malnourished child has an abdominal distension? Why should there be?
Vitamin D deficiency child will have protuberant abdomen because of hypotonia. Yeah, liver and skin enlargement will be seen as abdominal.
Why should there be enlargement of liver?
Chronic anemia in failure.
You see so many malnourished children, especially the marasmic ones. Do they have enlarged liver?
Rickets can have visceroptosis, which is apparent hepatomegaly because of the restricted space in the thoracic cavity.
Visceroptosis can be decided by your liver span. So it will just be a palpable liver, but your span will be normal. But can your span be actually increased in malnutrition? Fatty liver, very good.
Protein energy.
And what about calorie malnutrition? Does marasmus have a large liver?
No.
It's a protein deficiency with fatty liver. And therefore, this child, we want to see whether the calorie or a expect in this child. Do you expect a significantly large liver or do you expect a normal liver? Muscle mass, they are the reasonable. We don't expect a pathological liver in this, right? Yeah. And you need to examine neurology in a malnutrition. Why? Is preserved. What are you looking at, brain or CNS in malnutrition?
What do you want to see? Power tone, coordination, wasting involuntary movements, cranial nerves, jerks, out of all that.
Macronutrient deficiencies.
Why is kwashiorkor devil apathetic? When you disturb irritable, that's an encephalopathy. Right from then on, everything could be involved. There could be a myelopathy. There could be lower motor neuron lesion, upper motor neuron lesion. And therefore, in a severe PE, have many neurological signs also to be checked. They're of no significance as far as, but they are acquired due to nutrition. So you have an encephalopathy, you have lopathy, lower motor, all kinds of signs are seen. Do you want to check up the heart in a severe malnutrition? Is SAM, heart is enlarged? So what are you looking at heart in a severe malnutrition?
Nutritional anemia causing failure.
One sign that you want to look at is what kind of heart sounds the myocardium is producing. And when in severe malnutrition, even the cardiac muscle starts getting atrophied, you have what is known as a tic-tac rhythm. What is tic-tac rhythm? Normally the rhythm is tic-tac, tic-tac. Okay, the difference between first and second sound is small. Between the second and first is large. but that is lost in malnutrition, and the heart sounds are tick, 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 not lap, tap, lap, tap. That is not there. And that may be the early sign of a myocardial weakness. Right?
In fact, on an X-ray, you may see a smaller heart, especially in the calorie malnutrition. Normally you see a mediastinum maybe 60% or so. Here it may be much less in a undernourished, especially calorie malnutrition. Then also you like to look at pigmentations for specific signs of nutrients like vitamins. A is very important. Okay, perhaps more important than D. In specific like pigmentation, pigmentation, dry skin. Okay. So what would you look at? How will you see vitamin A? You know, probably it's two.
If he has light perception or uh,
Red dot spots, corneal conjunctival dryness. Yes.
Or knuckle pigmentation, dryness of conjunctiva, vitamin D we saw. So you look at specific signs of vitamin. Scurvy,
bleeding,
you think this child is likely to have scurvy as well? Why not?
bleeding stations.
History told you that there was an insurance policy against scurvy. What was that insurance policy? Breastfed, no?
Breastfeeding, breast milk is an excellent anti-scorbutic factor, and the child would be very irritable. Handling, movement, everything. And very uncommonly, we see scurvy in a malnutrition unless really severe.
I think one thing is you need a zero vitamin C intake for 6 months or longer to produce clinical signs of scurvy. And this was found out because when the sailors used to go on a long trip and they had to depend on only no fresh foods, and then they realized that it would take that long time, no vitamin C at all in any part of your food. And even then it takes long time. So scurvy is rare clinically, so subclinical scurvy may be common. And if a child who is malnourished is extremely irritable, then you start thinking whether it's a irritability of a subperiosteal bleed due to scurvy, and giving vitamin C 500 milligram once a day, 2, 3 days, the child stops crying. It's a good therapeutic case for scurvy. Otherwise, we will not see scorbutic bleeding. We will not see the gums bleeding. And therefore, I think vitamin C is not clinically evident, but it's certainly subclinically always there. So breastfed, no vitamin C, right?
Unless the
And you look
mother
at the
is also
skin.
vitamin C
Yeah.
there.
You look at the skin also. Okay. A dry, rough skin, even again, a low fat in diet. Okay. Essential fatty acids. Okay. So that is
Rhinoderma, we see here,
Yeah.
the little papillary eruptions on the back of the elbow.
ठीक है ले जाना है इसको डिस्टर्ब नहीं किया है सो गया ना हम ओके थैंक यू
Sorry, sir, I was sitting and all of you are standing. But That's true. Then the block the
Signs of micronutrient deficiency is present. Child's skin is dry and rough, and wrist widening is present. Frontal bossing is there. Developmental assessment. Gross motor, child can actually stand with support and walk with support. Bruising is present, but he couldn't stand without support. Fine motor, yeah, is appropriate for age. Social is appropriate for age. And language, monosyllable speech is only there. Bisyllable is not there. Expressive speech is not there. Systemic examination, only liver is palpable 1 centimeter below right subcostal margin, which is soft in consistency and non-tender. Liver span is normal, 6 centimeters. Rest all is insignificant. Summary, a 1 year, 3 months old male child, first by birth order and born out of non-consanguineous marriage, brought with complaints of fever with blue stools, is a case of acute gastroenteritis with no dehydration. In a case of uncomplicated severe acute malnutrition with severe anemia and rickets secondary to nutritional iron and vitamin D deficiency, with significant dietary calorie deficit and no protein deficit with developmental delay in language more than gross motor in a fully immunized child. Investigations done, CBC counts were 18,000 with lymphocyte predominance, 60% and neutrophils are 30%. Indices were MCV, hemoglobin 6.7, hematocrit 23, MCV was 45, MCH 13, MCHC 29, platelets were 4,22,000. And this is left wrist X-ray.
is there rickets on the X-ray? Any cupping, praying? No, not.
Thank
To call it SAM, severe acute malnutrition, this child doesn't fit in with that. Then undernutrition, what was his weight?
6 point
6
Four-
points.
four.
It-
9.
Call it severe acute malnutrition, not only based on height and weight. There should be signs of sickness, signs of protein deficiency, caloric deficiency, loss of subcutaneous tissue from all over the, including other class, including, in fact, from face also, which is lost the last, and therefore skin skin changes. So he's undernourished, no doubt. And as he start getting less of calories, the body adopts and the body stops growing. Therefore, decreasing your requirement of protein. You are able to manage in whatever little you get. He's undernourished, not too bad.
What was the height centile, the length centile?
It is between -2 and -2 and -1. Height is fine. Weight is less. Weight for height is less.
7 kg, 74 centimeters.
So look at the mother, probably she was also not very tall. 74 is not too bad. 15 months. No?
In one.
See, I mean, there's always a problem when these definitions come in. But what is your concept of severe acute malnutrition? What is wasting? What does the word wasting mean?
There is thinning, obvious thinning will be seen.
Yeah, so there is obvious thinning. What else does it mean? Which parameter should be low?
Weight for age will be less.
Weight for age should be
Less.
considerably low, right? What is stunting?
Height for age will be low.
Height for age should be considerably low. And then what is weight for height?
Weight for height.
When weight for height is low, what does it mean to you?
Acute malnutrition. Acute malnourishment.
Why acute?
Weight is a dynamic parameter, sir. Height.
No. Forget dynamic or non-dynamic. Tell me that if weight for height is low, why does it tell you acute? I mean, we're talking of a bit of basic principles of maths here. If weight for height means what? Weight upon height. So if weight upon height is low, what is low? Weight is low, or height is low, or both are low?
Weight is low for that height, then weight for height will be low.
So weight is low for that height when weight for height is low. Have you understood this statement?
Yes, sir.
Now, weight for height can be low in two situations. Weight for height low, but height normal for age. Means what? Only weight is low. Weight for height will bound to be low because weight is low. You got my point? This is only acute, as in there's only weight is less, right? And in your classic chronic malnutrition, there is wasting and stunting. So to start with, your height should be less for age. And for that height, weight is not even proportional to that height, but further less. That is your classic chronic malnutrition. You're understanding what I'm saying? So in this child, your initial starting presumption, if height is -1 to -2 percentile, your height is normal. Height is not affected at all in this child. Correct? So only weight is affected. So there is no stunting, there's only wasting. Right?
I think the word SAM has two components. No, it's severe and acute. So many of them come to you with an acute illness, but they're already severe, and therefore they're both components, and therefore the length is going to be less than normal, but the weight for that length is further normal, and therefore there is a chronicity and there is an acuity both. And that's why SAM, because how can there be severe acute? It's severe and acute. Okay, it's not an acute illness which was severe, but it's a severe illness. On the top, there is an acute illness.
So in that, the word severe is about time, not about current severity.
This child has chronic malnutrition and has now also evidence of significant recent loss of weight, and therefore he is acute. So if you want to work that, and then you could have that loosening of skin and loss of fatness. Clinically, to call it so-called SAM. Otherwise, best ways to, he has chronic malnutrition supported by his growth failure. In addition, he has evidence of acute malnutrition as suggested by the weight for his length and also other parameters like skin, which you mentioned relatively, yeah, mid-arm, and then skin, subcutaneous tissue, muscle mass, all this.
Because it is acute on chronic, they need to be hospitalized because that acute illness make into a problem. And therefore, at that time, if edema may be often acute in that child. And therefore, you have a hypoglycemia, hypokalemia, all that. And I think that is the acute part. But the chronic part is already there for a long time. So you admit them for the acute part. And then once they start feeding well, edema starts disappearing, then you get on to home resuscitation. And I think that's why SAM is severe and acute.
One thing here is when you were telling the history, the developmental milestones, the the head control was quite delayed, almost till 6 months. So one expected head control is delayed, maybe the nutrition is affected very much in the early part of life, including the weight also must be. But history-wise, we find that the initial part of the growth of this particular child was not bad. So the initial supplementation by way of was not bad. Then why did he not have head control earlier? Is something not very easy because otherwise the head circumference should have been relatively less affected.
Which means the history is incorrect. The mother had to be questioned a little
Yeah,
deeper.
maybe the head control, she didn't understand what exactly do you mean by head.
Next time the presentation, investigation should be put in a separate slide. If you take a snap, then we can't read the details and there could be something worth discussing on those issues, right? So just take a little more care on that.
Initially, when she started presenting, we thought that we are dealing with some chronic disorder with CNS affection, etc. But at the end, turned out to be very good for the parents.
So Dr. Anjali is asking what was done for the diarrhea. What was done for the diarrhea?
Plan ORS and zinc supplementation.
Just zinc. Means nothing specific.
Any
Medicines.
probiotic, prebiotic, probiotic,
Yes, ORS and zinc.
lactobacillus, nothing.
Sir, PPT is visible. Kindly make it full screen. Thank you.
Ten-year-old female child, fourth born of non-consanguineous marriage, residing at Govandi, hailing from UP, Muslim by religion, Qurayshi by community, brought by parents with complaining of fever since 5 to 6 days and abdominal pain since 2 to 3 days. Child was apparently normal 5 to 6 days back. After which child started having fever, which was undocumented, high grade in nature, not associated with chills rigor. It was intermittent and child was active in interfebrile period. It was associated with decreased oral intake and lethargy. Uh, Abdominal pain was since 2 to 3 days, which was localized in peri-umbilical region and epigastric region, which was dull aching, not related to any food intake. Uh, no aggravating and relieving factors were there. Uh, it was not associated with vomiting or loose stool. On inquiry, Mother told that she has noticed paleness of skin 1 week since 1 week, and it was progressively increased in nature. History of outside food consumption was there. No history of decreased urinary output or burning micturition. No history of bowel bladder dysfunction or blood in stool. No history of weight loss or Cox contact. Uh, no history of cough cold or ear discharge. No history of blood transfusion or any similar illness in family. No history of gallstones or previous surgery. No history of abdominal distension or bone pain. ANC history was uneventful. It was a home delivery with birth weight was around 2.2 kg. Uh, mother doesn't know about weight gain or the umbilical cord cut by which method. Birth history. It was a full term normal vaginal delivery. Baby cried immediately after birth. No NICU stay or neonatal jaundice. No history of previous admission. Immunization is still dead. Developmentally appropriate for age. Diet history. She was taking mixed food and majority of junk food. She was calorie deficit of 258 kilocalorie and protein intake is almost normal. Family history. There is no similar complaints in the family.
Okay. So 10-year-old with fever, abdominal pain. Now, this is the description. So what do you make out of it?
Child had high grade fever to start with.
Where is it? You put in any?
Undocumented but high grade.
At onset or later on? Not at all. So here what is striking is there is, after reading this, we don't know how this child's fever has progressed. ODP is not there because all fevers of 5 and 6 days are not the same. And the diagnosis is not going to be by investigation. Your ODP should, how was the onset? How was the child for 24 hours before that? The onset was low, high. How did it go on rising? The course was slowly rising. The course was intermittently rising and coming down now. In which case, you are not much worried even if it is day 6. Or it has been progressively rising. So are these not three different things? A high fever at the onset and the child is all right, like any viral fever, you are not worried. Started low, went high on day 3, again coming down day 4, day 5. Again, you are not worried. Maybe partially fever. But progressively rising on day 5 is what you want. So I would have said to start with, it was not a very high fever, but it went on increasing progressively till day 5, as suggested by the height of fever, the intervening interfebrile period, the activity of the child, not only when there was fever, but when there was no fever also. Because every child may look sick when the temperature is at its peak, but a sick child will look sick even when the temperature is. So this gives you an impression about what kind of illness you are looking at. A progressively increasing illness, an improving child, or more or less the same. Because this often gives you the idea of how to proceed for it. Okay. So was this child's fever high at onset? Probably no. It went on progressively increasing till on day 5, day 6, it was the worst. That means the height of fever was high, the intervening period was shorter, and probably the child was not as active as he was on day 1, day 2, on day 1. It tells you a sick child. Then your next question will be, where is the localization? So increasing trend in fever as the day advance. Now, what is the localization? That's the second.
So have you asked these details? If you have not asked, it's okay, but you don't know, right? On whether was it high on day 1 or was it not high?
It was not on high on day 1. It was progressively increased. But how can we will ask some, how can we ask the progression of fever to the parent?
Actually, you have to spend some time. This is difficult as in you can't just say "Kya fever," as sir said. So this same 5-6 day fever, we can give you a different progress and make the first fever viral, second bacterial, third malaria, fourth immune mediated fever, and fifth beginning of SOJIA. Same 5-day fever. I can give you 5 different patterns. And yeah. So you need to ask this. So means first of all, you have to ask open questions in history. What is open question? What is closed question? Yes, no type. So if you ask, अच्छा बुखार जोर से था, they will say yes, ना चल आगे बढ़, जोर से था, yes. So that doesn't mean anything. You have to say पहले दिन बुखार कैसा था? इसे जोर से था. जोर से था तो कितना जोर से था? बहुत जोर से था. दवाई देना पड़ा, कितनी बार देना पड़ा? You have to ask multiple questions to corroborate this way. Then you know that in the given 24 hours, how high was the fever, right? And then say, दूसरे दिन क्या हुआ? तीसरे दिन क्या हुआ? You may think this is stupid, but this is the way you have to ask for the first 4-5 days. Then you will get a fantastic picture of the fever and you almost have made half your diagnosis, right?
More important than ODP in fever. Otherwise, you are lost. Then ask for everything under the sky by way of investigation.
So I think just now we don't know much about the fever. Now, what about, and again, try to understand. See, I know you are very young, you have a long way to go, you have to learn. But child is active in interfebrile period and then associated with lethargy. So the two things don't go hand in hand. So everything that we are asking, we have to understand and ask and understand their answer also, right? Because you're looking for something when you're asking. You're not just collecting data just to put down on paper, right? Fine. Now, what about the abdominal pain? So, what do you think? What does this sound to you from whatever details you have got? I think it's acute appendicitis. What do you think? No?
Sir, abdominal pain is not localized. The periumbilical and epigastric region is paining more. If you are saying appendicitis pain, it has to be right.
But it starts in the periumbilical region, no? Appendix pain, or it doesn't. Anyway, so what does this periumbilical and epigastric, why do we ask the site of pain in the abdomen? Does it mean anything to us? What is the interpretation when the patient tells us the site of pain? How do you interpret it?
Site of the organ which is involved and
Very good. So you look at the underlying organs and therefore you come to the anatomy. So in periumbilical and epigastric, what are the organs?
gastric.
Okay, so gastric, then
And
pancreas, then small intestine.
intestine.
Okay, very good. Then lymph nodes. Yes. And peritoneum. Okay. So now from this description of the pain, can you try and figure out which of these structures are possible?
Even is dull aching, can be gastritis. Epigastric.
Some element of gastritis maybe because of epigastric, and then periumbilical. What is the nerve supply of the omentum and peritoneum?
So does that dull aching mean anything to us? And also, how do you get a history of dull aching? How do you ask the patient, how was the pain dull aching, and they say yes? See, all these things are, you may find them like so basic that you, अरे हम तो MD pediatrics कर रहे हैं, ये क्या junior KG का सिखाते हैं? But this is the crux of how you will use history in future if you want to use. If you don't want to use, then fine. So dull aching means what? So suppose I have dysentery. Will I have dull aching pain? What? If I have bacillary dysentery, will I have dull aching pain? Yes or no? Common sense. What is paining in bacillary dysentery? Brain, heart, lung. So how will the pain be? Colicky pain.
The meaning of tenesmus
Pain during defecation.
during purification and getting the is it small intestine gastrointestinal junction where rectocolon. Okay, it is rectocolon. It's like those feels like going. Organ which is involved and that is there. It's inflammation more or less constant. Is not you ask all these questions. Vague.
Okay, now it's almost 8 o'clock. So quickly come to pallor. So we need much more detail.
Well, dull word means that it is just discomforting. We call it pain, but it is discomfort. Okay. And what does it mean? Very likely with this kind of uh, anatomical position, epigastric and periumbilical. You think there are two different things? No. The epigastric one has become periumbilical because periumbilical can't become epigastric. So epigastric is what? Stomach. Why should it become periumbilical? No. Pancreas. Why should it become periumbilical? So it has to be liver. And what is dull ache? And just distension of liver with stretching of capsule. So you got a hepatomegaly there straight off. And that is the dull ache. Epigastric becoming periumbilical. What does it mean? It's a chronic problem, not acute. If it's acute problem, it would have been very severely painful. So this child's discomfort is now being felt when the liver has become large, but the liver has started becoming large some weeks ago, maybe months ago. So here we get an idea that it's a chronic hepatomegaly gradually worsening, and therefore the history of recent discomfort.
So just like we talked dysentery and colic, dull aching as a means enlargement of an organ, stretch. So what we are trying to say is everything has a interpretation. Now, what about the pallor? You are saying on direct
Now you
questioning you
get
got
straight
pallor.
a pallor with hepatomegaly plus minus splenomegaly. Okay. Can it be deficiency? No. Can it be bone marrow aplasia? No. So it has to be hemolytic or maybe a storage, leukemia, any other storage. So you just tell us now between the two what we have, and we get a diagnosis only with it.
Got the point?
Now it's not difficult. Now it's not.
So now you have to debate between a bone marrow issue like a leukemia, or you have to debate between hemolysis. Is it hemolysis? What would you look for, etc., etc.?
Jaundice will be there.
Very good. So there'll be jaundice. Okay. Then
Mm.
hemolytic paces. So basically, first you have to look at whether it's a chronic hemolysis or a acute acquired hemolysis. If it is chronic hemolysis, you'll have a long past history, no? So you have to ask whether the child was absolutely all right. If that was there, then all that is gone. All the previous thalassemia, this, that, all that is gone. Okay. And what can you get acute hemolysis with fever, hepatomegaly, pallor? Acute hemolysis.
Oh, um, there is there can be clinical signs like tachycardia in acute hemolysis.
Which condition of causes acute hemolysis, and it will have fever, it will have hepatomegaly, it will have pallor.
Sickle crisis.
Okay, acute sickle crisis. Anything else? So malaria, you have autoimmune hemolytic anemia triggered by a fever, right? Of course, so that's why lots of details are required about the fever to be able to fit into any of these, right? Shall now quickly come for examination. It's already 8 o'clock.
Sir, on systemic examination per abdominal finding on inspection, it was non-distended abdomen, no scar marks or any dilated veins or sinus thing. On palpation, liver was 5 centimeter below the right subcostal margin, which is having round borders, firm in consistency, non-tender. Liver span is around 10 centimeter. Left lobe was not palpable. Spleen is 3 centimeter below the left costal margin towards umbilicus, which was firm in consistency, non-tender. Uh, grade 2 by Hackett's classification. On percussion, tympanic note all over the abdomen except uh, the area where the liver and spleen was enlarged. Rest systemic examination is normal.
Clinically, any diagnosis, provisional diagnosis?
No, sir. No. OLD is negative and Vidal we have sent reported yet to come.
You have a CBC?
In CBC, HB was 5.4, with WBC counts of 6,000 and platelet were 1,66,000. Info predominant 43% and neutral was 49%. Mixed cell were 0.5%. On PS, peripheral smears are hypochromic, microstatic. Teardrops are present. Pencil cells are also present. ESR was 75 and arretic is 0.5%.
Any other investigation? What is the growth of the child, height and weight?
Height, weight, and BMI all are belonging to the -2 to
Tell us the
-1 to.
values. Tell us the values.
Weight is 24.7 kg. Height is 130 centimeter and BMI is 14.6.
Okay. No other investigations. Okay. So what do you think from this CBC? Any thoughts from this CBC? Do you think it's a leukemia?
No history of weight loss or
Leukemia is a acute condition in pediatrics. There will not be weight loss. But there is low hemoglobin and platelets are like borderline, no, 1.66. So clinically, whether the child is looking sick or not, that is extremely important. So that is the crux, no? And then you say differentials are normal, everything. So therefore, no leukemia. Okay. Do you think this is hemolysis?
No.
Could be. So could be means then how do you, what should you look for? So all acute hemolysis should give you icterus, no? So there was icterus?
No.
No. So that goes against hemolysis. Could it be just iron deficiency anemia?
The concomitant vitamin B12 deficiency, that two lineages are affected. One is RBC and one is platelets. Maybe dimorphic anemia.
So dimorphic anemia is possible in this child. The question is the current illness due to that dimorphic anemia or the dimorphic anemia due to the current illness, or two are unrelated?
Splenomegaly is not. Hepatosplenomegaly is there. I think both are unrelated.
Hepatosplenomegaly cannot be explained by deficiency anemia at all, right?
I think we have said it cannot be acute hemolysis because there is no jaundice. It's not chronic hemolytic anemia also because the height is fine. And therefore, this is something certainly other than hemolytic. Then what? Could it be acute bone marrow? No, but he is not sick. So the question is, which other conditions have liver and spleen and significant anemia? Could it be past history of repeated malaria and now you have another episode? That's one possibility. Or another possibility is that these two things are different really. The fever, what Dr. Khare was talking about, we don't know detail. So child with some hepatosplenomegaly going on for some time, not too long, but maybe few weeks, months, has now got something else. In which case you start looking at the disseminated thing. Now, if you feel all are together and pallor is significant, then it's a hematological problem till proved otherwise. It's not simply an Epstein-Barr or leptospira or all that. No. And therefore, at this point of time, we are not sure what we are dealing with. But if he says fever patient is not sick, then bone marrow is unlikely. Because every other bone marrow condition would be sick. Then I am forced to say that two disorders are different, but that's not a good idea to go by. We must put all together So again, we'll have to look very carefully where we are in the history itself. And as of now, we don't. So again, every Wednesday, every Thursday at the end of this, we request you to tell us what has happened to the last week. But we never get to know that. And the reason is next time there will be new, different people. Okay, and we are all the old people here asking for the same thing. That's not fair. Children suffer so that we could learn. And we cannot waste their suffering. Okay. We have to learn from their suffering so that the next sufferer can be managed better. We are not getting that. And I think that's my big complaint. So you must find a solution to it because how can we not check the history again? I would be happy if one of you come next time and said, we reviewed the whole history again, findings again, and we realized we had missed few things and now we know the diagnosis. Then I think we have learned. Otherwise, every time what we have learned is we have not yet learned. That is all that we have learned. That's not fair. That's not fair. We also come here with idea of learning more and only telling you that even at my age, I want to learn. At your age, you must want to learn. So I think take care of this, isn't it? Because it's not only you are all going to pass. Even we passed. Okay, passing exam doesn't mean anything at all. Who is the person who has joined medical college but left without a degree? Almost never. Difficult. So all of us are going to pass, but we need to learn more, just not pass, right? So take a note of it. I think from next time we want to know what has happened to such patient, or at least we want to know that oh he went Dhamma, he was tired of us, and we lost to know. Okay, but we must know that, right? Okay.
So we have given him transfusion by 5 cc per kg uh, 1 day back. And today it's transfusing by 10 cc per kg. But the liver and spleen both are there, not regressed too much.
Any update of last time's case?
An update is there. When Rajesh Udani sir came to discuss two neuro cases one day, one is we presented one case of autoimmune encephalitis. Sir has told that this is not looking like autoimmune encephalitis. You bring the kid to Hinduja hospital once. I have to check him once. We have taken the kid there. Sarah has asked us to repeat LFT and repeat USG. His LFTs were deranged comparing to his on admission also. His LFTs little bit of transaminitis were there. But the values are OT and PT are less than 100. But again, when we had it repeated, the values are around in 200s range. Sarah's told this may not be autoimmune encephalitis, but we treated the kid as autoimmune. Then we discussed with the professors and our neuro team. Then we have sent ammonia levels, which came out to be 320 in that kid. Then that day itself, we shifted the kid to PICU for sodium benzoate infusions and SOS plasmapheresis. We suspected then it we suspect urea cycle disorder. It might be urea cycle disorder, not which is mimicking as autoimmune encephalitis. But unfortunately, we lost the kid. One update on that.
Thanks for this information. So again, as sir said, what we learned is if you remember that clinic, whoever were there, Brajesh Udani sir had said here only that these features don't look like autoimmune. And when he saw the MRI, he said it's strictly not looking like autoimmune. Right? So I'm just saying that we should learn to pick up the differences or the unusualness. Today also we told you what is the difference from a normal gastroenteritis that you should pick up, right? Good. Thank you. Yeah. So give us a feedback of this one also next time. Actually, by next time you will also forget. So in 1 or 2 days or 3 days, when you get some more diagnosis, you just put it on the Thursday class group, no? So everyone will come to know and everyone will understand.
Style. When she came, she was not that sick looking. we initially sent primary investigation. We suspected malaria. But then her hemoglobin was turned out to be 5.4 and she had significant tachypnea. We thought the child is in failure and we transfused her initially by 5 cc per kg. But even after transfusion, her tachypnea is still there, but X-ray is not correlating with her tachypnea. We will update you, sir. We are still working on it. Then our professor ma'am said rule out COX in this child because her ESR is also high and rule out first primarily rule out COX in this child. We'll update you.
Okay, stop here. Anything from any comments, any questions, any points?
No, Rajesh. Thank you. Thank you very much. Thank you, Dr. Amdekar, sir.
Thank you. Thank you, Anjali. Thank you, everyone. So we meet next Thursday again. Thank you.
Thank you.